Good evening or good morning, depending when you are listening to the podcast. Tonight, I have a very special guest, other than a dear friend and somebody that I admired over the years. It's Dr. Mc Allister. Dr. Mc Allister, it's okay. I have to, talk a little bit about you because we have different generations that listen. I, I've read almost every consensus that you wrote about bone regeneration, and that was always fascinating. I used to tell the residents, if you get stuck in quoting something about bone regeneration, Mc Allister will be the safest one to quote. So on that note, you have made a career in research about allograft, and so you have a PhD and a training of periodontics. Very, very admirable from one of the best schools, San Antonio, Texas, at the time that you did. You got your DDS from University of Washington. You practice in Oregon, so you basically zigzag back to West Coast, and probably you'll tell us a little bit about you towards the end, because I know how much you like the wildlife and the outside life. Um, and so you are boarded in periodontics in oral implantology with the ICOI. We both of us are fellow of the ITI, and you are fellow also of the International Society of Plastic Surgery, Periodontal Plastic Surgery. And you've done numerous papers. We can spend the whole night referencing them and chapters and so on. So I am very, very honored to have you on my podcast. And so welcome on it. And without any delay, let's dive into the source of the talk today, which we're going to talk about allografts. Um, Allograft, as we always talk, you and I, about it, it's still some people are suspicious about it, not very confident about it, although things have evolved drastically, and that's what we want to address. So, the interesting part about you, Brad, that you have introduced, or you talked a lot about stem cells, and you've done a big research. There was a publication 1998 which talked about the viable cells in a graft. So, would you like to drive us and tell us about it, how you ended up in here, and what brought you into that subject early on in the early 90s?
Well, it was kind of an interesting pathway. I originally started doing a lot of preclinical work with BMPs and PDGF. I also had a lot of in vitro experience with both of those molecules. When we were doing a lot of those studies, one of the things that we noticed is that autogenous bone, which was our control, would form bone more rapidly when we looked radiographically and histologically. And it became pretty evident that it was because you're delivering cells. So even though the BMPs and PDGF are very potent at helping the bone formation, the timing of it was a little bit delayed because you had to recruit cells. So early on, myself, as well as other researchers, Jeff Hollinger was a big influence. He was also up at Oregon Health Sciences University. We all felt that if we could deliver cells in addition to these growth factors in some sort of form or combination, that we would be able to, I think, get the best results. So it was something that as early as the late 90s was part of my goal to basically replace autogenous bone grafts with some of these growth and differentiation factors and the cellular component.
So that's a good segue to talk about autogenous bone. So autogenous bone, back as you mentioned, it was the gold standard, and that's what everybody used for big cases. So do you still think that uh, we can count on that, or things have evolved? What do you think about that?
Well, I think older guys like you and I, we still use the autogenous bone as a gold standard as a statement. But I think it's more of a historical statement in the sense that if we look at our literature, there is a very nice body of literature addressing autogenous bone in a variety of fields, whether it be orthopedics, oral maxillofacial, periodontics. So there's definitely a lot of research there. But Over the last 20 plus years, we've seen a tremendous increase in the literature with the use of allografts, showing as good or superior results. So, I consider that more of a historical gold standard. We know now we can accomplish similar results or maybe even better results when we start looking at patient-related outcomes. In other words, postoperative complications, pain, cost, all of those other factors.
Hmm.
These other approaches are far superior. So I like to think of it as more or less a historical gold standard and know that now we have other approaches that can accomplish things, that's a better outcome for the patients when you take the full body outcome.
Yeah, I mean, especially the amount of available autogenous bone, especially in the oral cavity, to create big or reconstruct big defect is not an easy thing. Now, to focus a little bit about autogenous bone, before we move to uh, your fame, which was the vital cells. In Europe, they are big on autogenous bone, obviously, but not the autogenous bone that we used to talk about it when we were training at the beginning, where you take viable osteoblast. You have the people like Professor Khoury. He says that monocortical plates have the potential of delivering viable cells, although in America we call them avascular bone. So, what's your take about that subject in general?
So I think that's evolved quite a bit. And I do believe osteocytes play a valuable role in the whole regenerative process and might be jumping ahead a little bit, but that's one of the nice things about the new cellular bone allograft origin that's available is that they're using cortical bone. And so I think probably ideal is the combination of both, but sometimes you're only going to be able to get monocortical. Say, for example, you're scraping in the localized surgical site. So if you're just using a scraper, all that is going to be autogenous bone with very limited cellular content with it. So you're not going to see a lot of osteoprogenitor cells, stem cells, not even a lot of osteoblasts, but you will see osteocytes and obviously the minerals that are present or the growth factors that are present in the mineralized structure can be released and that can stimulate excellent healing with that. So I do see value more than I used to with cortical bone. It's great for space maintenance.
Mm-hmm.
Um, but I think the cellular component is still an important one. And if you can have kind of a combination of both, make sure you have enough cells, that's going to give you a superior result compared to just the monocortical approach. And if you look at Professor Khoury's work, a lot of what he does is use those monocortical blocks. And what he'll do is he'll then pack bone of higher quality, more cellular bone in between those, and he'll use essentially the cortical component more for space maintenance.
Correct.
And that combination gives the space maintenance plus then the cellular component to get a robust bone formation. So I think the combination can be valuable.
Yeah, and that's exactly what I was hoping you to touch. It's a combination of things that he's doing, is creating a space, and that is very very valuable in bone regeneration. Uh, so, having talked about autogenous bone, let's pivot back to the common things between you and I, which is an allograft. So, allograft 90s was, as you mentioned, was really behind. And then we got the 2000 where they were able to keep the structure of the minerals itself. So before we dive into the viable cells in it, tell us a little bit more about your thoughts about the processes, how things have evolved better since you did your whole life on these things.
Yeah, so it was kind of interesting. I started my training with demineralized allografts, and while we certainly had some nice results, things improved dramatically when we moved to mineralized. And then I think we got an improvement beyond that when we combined the two. So that way you had both demineralized and mineralized. And that concept is utilized with the cellular bone allografts. They have a mineralized component and a demineralized component. So it's kind of getting the best of both worlds. So what's happened is the allografts, as they've changed, they've taught us a lot about the whole regenerative process. Now we have designer allografts, not just the cellular bone allografts, but designer ones that have good space maintenance and have a combination of both mineralized and demineralized, which really gives us opportunities off the shelf to accomplish great things. So it's really evolved nicely and it's helped us understand really what's happening with bone regeneration. And then it kind of jumps us into the cellular bone allografts, where again, you get a demineralized component plus the cellular component. And that gives us, as far as allografts go, the best results that we've seen. And that's just been this slow progression over the past 25 years.
Indeed. And so let's get into that right now. So see, that's why I wanted to get to it logically. So you were one of the pioneers of viable cells. I know you're a modest person, but you are one of the pioneers, and I admire you for that. You stuck by it. You did not give up. So now we are where we are today. Just walk us through this journey, because this is really fascinating. I want people to, because last time I was lecturing to the residents at UPenn, they take it for granted. They don't know what we went through with failures and stuff. So just one thing that before I forget, and I'm sure you share with me, and recently Dr. Becker passed away, but Dr. Becker, you remember in his famous paper of 93, he said, if you put demineralized freeze-dry bone in the socket, you're actually inhibiting the healing of the socket. You remember that famous paper? So I, I'm going to give it to you here because I know you have so much to talk about that. So please go ahead and tell them how lucky they are right now.
Yeah, it's it's a much easier field than when we first started, where we were going in different directions. I think both you and I, early training, we did things like block grafts from the symphysis, which worked quite well, but again, a bit of trauma to the patients. And I think moving to the whole allograft field gave the patients a much better experience. It made the surgical times a lot less. And so as we transitioned through these different eras, some of the approaches didn't work out quite as well. And it's been a nice journey, and I'm super happy that the cellular bone allografts have, in fact, sort of shown the test of time. I first brought osteocell in 2007 into dentistry. It had just started being used in orthopedics. I was very familiar with Osiris, the company that had created the technology. And then basically it was being used in orthopedics. And I thought this would be fantastic for dentistry. And so we did multiple studies with sinus lifts. We studied in perio defects, and we saw such robust healing with that. And it's an option that's, again, off the shelf. It may have to be in a freezer, a -80 freezer, but it is off the shelf, which makes things a whole lot better. And then we've seen over the course of the last 15 years, these grafts have evolved, and we're now probably on third generation grafts where they've made subtle improvements to them, much like we saw with the non-cellular allografts. The first iteration, the demineralized approach, wasn't the best. It's not what we use today, but it was the starting point. And then combinations and manipulations and different particle size, all of those things together have come up with something that we can use very predictably for our smaller, easier defects. And then when we get to more complex, bigger defects, we can move to the cellular bone allografts. And these second, third generation approaches have capitalized a lot on what we've learned. And Origin, for one, is the one that we've been kind of doing some research together on. They actually are relying on osteocytes to do a fair amount of that stimulation. And if you'd have asked me 15 years ago, I would have said, oh, osteocytes are useless. Why would we care what they're doing? We thought it was all stem cells. And in fact, the results aren't as good when you have just stem cells, because you have to differentiate the stem cells. So there's a whole process that goes through. So having these committed cells, so they're already osteoprogenitor, osteoblasts, and osteocytes, that jump starts this whole healing process much more rapidly than actually if you just delivered stem cells alone. So we've just basically learned over the last 25 years all these little subtle things that everybody now can enjoy. The residents now can jump right in and get a very powerful graft material just by picking up the phone and ordering it. And while Autogenous bone is still a great alternative. I have occasionally patients that want autogenous bone. It's nice that you're not dealing with the complications, and I really think it's a better service to the patient if we can
Okay.
use allografts, and that's probably 90% of what I do is allografts opposed to autogenous alone or alloplast alone or xenograft alone. I might add some of those others to the graft. I still add autogenous if I'm doing a small defect and I can scrape a little autogenous bone. I'll add that to my bone graft material. I'll add it to my allograft. I think it certainly is going to help. And when it's a localized defect, there's really no added time, no added trauma to it. Very different than if you're going to a whole separate surgical site, going to the symphysis, and now you can have those complications, plus the patient's in a lot more pain than the actual surgical site. So I think we've come a long way. And unless you experience that journey with the rough seas, I don't think you appreciate it.
Yeah, true, true. Yeah, it's hard unless wet your hands like this, and let's face it. Sometimes other than creating another site, you take the block and you put it, and somehow the block, you know, poke through the tissue, necrosis on you, and stuff like that, and then it's tough to explain to the patient and put them through a lot of surgeries and risk it all. It can happen. It happens actually quite a bit. So I'm glad that you mentioned that, and you mentioned the osteocyte, because right now once we talk about stem cell or viable cells, we cannot forget to talk about all of these products that exist out there: PRP, PRF, BMP2. We don't talk about BMP2, recombined human BMP2. It was for some time we had huge talk about it, and then all of a sudden now you see a lot of PRF, which you were mentioning, growth factors, uh, but nothing like in osteocyte. So let's talk about them. We're going to talk about the bone substitute. So what is your take on all of these material that exist? PRF, PRP, PDGF, all of them that we have available right now.
Well, I mean, I think they all can help if used
Mhm.
in the correct setting. I was on the clinical trial for the FDA approval of PDGF back in like 2005. And so I've seen some, beautiful results, the research results, the histology. So we know that it can enhance healing, but we also know it's slightly delayed because it has to recruit the cells. So it's a black box, the healing, and there's a good 200 different things going on. But if you can put in a supraphysiologic dosing of BMP2, of PDGF, or a gamish of growth factors, that could be imdogain, PRF, PRP, we can enhance and we can push things in the correct direction. But it's again case specific. I'll give you an example. There are people using PRF for a molar socket that Dr. Becker would never bone graft, has a buccal plate, has interradicular bone, and they're going and charging a patient for PRF and bone graft and all of this when we know a blood clot alone would heal beautifully in situations like that. So I think you need to have an understanding of the biology and use those products instead. If it's a diabetic and thin tissue, that's where maybe PRF really helps
Correct.
because it's going to enhance the soft tissue. It's going to make sure you're going to have closure, and that block graft you talked about dehiscing through, that's where maybe we can get that enhancement. So understanding what each of the growth factors does and how it can help you in surgery, I think is important, because it's not like you can have a practice and only use Imdogain or only use PDGF. You have to understand how each of these enhances the wound healing and then try to pick the appropriate patient for that specific product. It's just like treating periodontal disease. You don't use a laser for every case, right? You don't do open flap osseous for every case. You have to look at every case and make individualized approaches so that you get the best treatment for the patient, depending on the defect and what you're trying to accomplish.
But that's a very good point that you're saying. So once I was watching my friend Dr. Mish, Craig Mish, right? He talked about it's like putting a booster in your in your car and you get you the boost and then it drops down. I'm sure you heard them saying that. Um, it's a valid point. I do agree with him on things. So certain things. So it goes up and it comes down. So you just mentioned very well, and that it's all about sequencing of events. That's the beauty of the healing. So for a clinician that is getting introduced and is going to listen to you and I talking about these things, but here he's been bombarded by people. So put PRF, and if PRF is going to, it's like the holy water. It's going to come and brings everything in. It's just coming out of Easter. So it's the holy water that's going to create for you the bone. And sometimes it's so if you, so I don't want to say my opinion. It's not about me. It's about somebody smarter than me today. So how would you tell these guys that there is certain things that help the soft tissue, certain things help the bones, and so on and so forth? Would you please, help them understand it, and not to make it too complicated, but
Well, I think the important part is to be careful who you listen to. If you're listening to company sponsored discussion that doesn't really look at the research, I think sometimes case reports and just um, the holy water, as you put it, and this is with any material, can get us a little too optimistic. So I think taking a step back and trying to evaluate things from a non-company standpoint and look at the actual research will make a big difference, and see what the research shows for each of these materials, because pretty much each one of them has pretty solid research explaining what situations it works in and what it does. So just to kind of, quickly go through, I mean, I think the PRF, PRP, PDGF, I think those approaches help the most with soft tissue.
mm-hmm,
We all know that if you have excellent healing soft tissue wise, that's going to enhance your bone result. And
mm-hmm,
so I think you pick the right patients, and those are critical to getting a good result. I gave the example of a diabetic. If it's just somebody with thin tissue and you're doing a fairly large graft, it can be important. Even though tension-free closure, good suturing, it still helps if you have something that will enhance soft tissues. So I think those products clearly do that. The other avenue that they do is they are good at recruiting cells. So they can recruit cells, such as stem cells, to the environment and help if it's a situation where maybe you don't have the best quality of cells locally. That being cases where it's pretty dense
mm-hmm,
bone. It's a little easier in the maxilla to decorticate, and you know that you've got kind of cancellous bone right there. But in the mandible, a lot of times you're dealing with a monocortical defect. So even if you decorticate, you're basically still in cancellous bone. So all that does is it just stimulates the resorption, which can be good too, but you're not going to get to a bleeding site. You're not going to get to a point where you're going to recruit cells. So understanding how these materials recruit cells can be helpful. But then you've got other choices, such as cellular bone allografts, where you're delivering the cells to the site right at the surgery. So we don't have to wait for that recruitment. And I think understanding that can be very valuable in the situations where you want a rapid response. If you're okay with 9 months with a larger defect, I think that we can use a lot of our traditional materials for, say, a sinus graft. But if you look at what we were able to show with the cellular bone allografts, in about 3.5 months, we were able to create very high percent of vital bone and very low amount of graft material left. We weren't able to get that with allograft alone. And so I think it's kind of, what is your timing? What does the patient want to do? Are you going to be putting your implant entirely in regenerated bone? If you're going to put it entirely in regenerated bone, you probably want something that's going to form high quality bone fairly rapidly.
mm-hmm,
BMP2 we know is a very potent differentiation molecule with bone. It doesn't really help the soft tissues so much. So you wouldn't want to add BMP2 if you had some of these soft tissue problems that I mentioned. But there are studies that have looked at the combination of PDGF first, then you deliver in a controlled release environment BMP2 secondarily. And that combination can give you some of the best results. Unfortunately, That's going to be a tough one to get through the FDA, but there certainly have been animal studies looking at that combination where they're putting PDGF in first, because again, that recruits cells and helps with the soft tissue. And then you lag behind with the BMP2. Once the cells are present, you're differentiating them, getting them jazzed up to form the bone. But the
Hmm.
problem is, again, without the cells, everything is delayed when you compare to autogenous bone, especially extraoral autogenous bone or cellular bone allografts, where you are essentially delivering cells to the area on day one of surgery.
So I want to go back to the osteocyte because you mentioned an origin, and that's how we reconnected, you and I. Um, the importance of that, because we learned in biology, osteoblast, osteoclast, osteocyte is a formed cell inside, has nothing to do with anything. So can you please elaborate a little bit? How did we know now what we know, that osteocyte has a big role? Let's not put it major role, but it's a big role in in
Well,
healing, in enhancing the healing.
yeah, you hit it on the head. We always thought of it essentially as a useless cell, and we would determine dead bone versus viable bone by the presence of osteocytes,
Osteocyte,
right?
yeah.
In other words, your histology would, if it was an empty lacuna, you said, oh, well, it's dead bone. But a vital one would have vital osteocytes. What we have learned now is that there is communication, and I always think of the osteocyte as the conductor of an orchestra.
Correct.
So they aren't necessarily the most potent, the osteocyte does not form bone. So you can't get by with just delivering osteocytes to get it. But what the osteocytes do is they are communicators that orchestrate the whole process. And this is something that I had underestimated. I'll give you a really good example of kind of something that we should have figured out years ago. But if you look at fracture healing, when you have a fracture in a long bone, you basically are fracturing cortical bone, which, if you look at it histologically, has very little in terms of osteoblasts, but yet fracture heals quite rapidly. And it can be a pretty profound fracture, and it will heal beautifully, even without the aid of any of these components to it. And I think the majority of that effort is because what's happened is you disrupted the osteocytes. And when they get disrupted, they're the ones that send out the SOS signal. And so
Mhm.
essentially, they're doing this orchestration process that controls that healing. So again, the cells themselves aren't what's forming the bone. They are not osteoblasts, but they are basically signaling the whole process to happen. And I think we just underestimated how important they are, even though it was just something that was right there for us. Like I said, fracture healing, we should have maybe figured that out, but it took us a long time, and we were so focused on these other cell types because we saw them forming bone, right? You can look at histology and you can see an osteoblast line up, and you can see the new osteoid that they just formed, and it's beautiful histology, and you say, wow, we love osteoblasts.
Yeah, and that's what I mean. Basically, Professor Corey, when he takes the monocortical and he scrapes it to collect this bone that he puts it in between, is basically collecting osteocytes, as you mentioned, and it's actually you're right. You're a very more refined guy. You want to talk about orchestra? I'm going to say it's like a command center of dispatching all kind of things. And you're right about it. That's what I wanted people to understand, that we are overselling autogenous bone alone. Yet uh, there's more to the game, and that's how this new product that we have, one of them is Origin, is helping us a lot in enhancing the wound healing with using of the allograft. So so that brings us to the xenograft. So you and I, we are ITI fellows, and we know Dr. Boozer loves xenograft, and him and I almost scheduled together. I invited him to have a discussion about it. But I mean, seriously, today, with what you know and what I know and what a lot of us that spent their career on these things, what would you do a xenograft? What's the benefit of it? I'm gonna leave
Well,
it up to you. I'm not gonna say anything. So I'm gonna be
no, I
polite
mean,
tonight.
your opinion is extremely valid. So I'd be interested in hearing it as well. But for myself,
Mhm.
I use less xenograft now than I used to. The thing that I always liked about xenograft historically is that it has good space maintenance.
That's correct.
And so what I find myself using xenografts for now is what I call contour grafts. And I think that that's basically a Dr. Boozer concept, is having contour grafts so that we know space maintenance wise xenografts can work quite nicely. So oftentimes what I'll do if it's a very large vertical or horizontal defect and I use either cellular bone allografts or if the patient had requested autogenous bone, and then I go to place my implants at the second surgery, that bone is all regenerated bone. So if you go injure it by doing
Wonderful.
your osteotomy, there's a risk to that new regenerated bone. And so what I will typically do is I will put a contour graft on the buccal plate because we know how important having a good 2 millimeters of bone is. Now, if you've waited and the bone quality, really good cortical bone, maybe that's a different story, but most of the time we're going in fairly early, especially with these cellular bone allografts, 3.5 months, 4 months, and we want to protect that buccal plate. So that's an example where I will use the xenografts because I think adding the xenograft gives that space maintenance, protects that buccal plate. It also can be very aesthetic. If you're working in the anterior maxilla, and you've got a pretty big defect, adding that can enhance the aesthetic outcome with it. It just has that dimensional stability. I'm not as excited to have it around my implants. It just doesn't disappear. It doesn't
Mhm.
remodel. So that can lead to problems if you have periimplantitis or other situations. And so I think kind of that combination is still a valuable use of xenografts, but again, it's sort of a combination approach. So that's my xenograph kind of go-to
Yeah,
application.
no, absolutely. So I agree with your periimplantitis on the contour and all of that. So, but as you said, it doesn't go away. Just let's explain it to people why, because it's basically heated and there's no organic material, so it doesn't dissipate. Uh, so can't we produce the same contour with more of the cortical bone and the allograft? Nowadays, that this mineralization of the bone has created this the same effect that xenograft was famous about. What do you think about it? Can't we create this contour effect by just cortical bone, mineral cortical bone?
So I think the answer is yes, but I will tell you that there is a patient variation. And you and I have both had cases where you can do amazing things surgically and they come back and it's gone. It just has disappeared. And I'm talking mineralized cortical
Mm-hmm.
bone disappears. That doesn't happen when we use xenograft. So, I can do 10 cases with xenograft and I'll look at a CBCT later and all 10 of those cases, that bone will probably still be there. Occasionally, I'll find somebody that can even resorb xenografts, but I would consider that much more rare than 1 out of 10. Whereas I think when we're using mineralized cortical, I
Mm-hmm.
think for a lot of patients, it can work beautifully for a contour graft. But I have seen numerous patients, and I don't know the exact percent, but I might throw out 20% of the time, these patients that are just heavy resorbers. They're basically what happens is they're on the periosteum. I think that they just have this ability to just resorb almost whatever is there. It's just a very highly reactive periosteum, and that remodeling, is critical. So I think you're certainly correct in most cases, but I think if you were to take 20 cases, there'll be a few of them there you'd get more resorption. So I might base it on the patient. If I see real thin bone everywhere and I didn't get quite the robust result I wanted, that's when I probably go to xenograft because I'd be worried about it resorbing. Most of
Mm-hmm.
them, you're absolutely right. That's very reasonable for a contour graft.
Excellent. So we're getting to the end. It's fascinating. I would tell you, I've done a lot of these podcasts. This is one of my favorites. So I'm not being, I'm sorry if I upset anybody who's going to listen to that afterwards, but thank you, Brett. The the cost of these materials is becoming expensive, especially when we deal with these viable cells products. Um, the sizes also are important because they come with one size and sometimes it's difficult for them because they move them from orthopedics to oral. So what do you think? What's your thoughts about that? The size and all of that.
Yeah, I mean, I think you hit it on the head. Coming from orthopedics, it's at a disadvantage to us. What's kind of exciting about Origin is that this particular cellular bone allograft is designed specifically for the oral cavity. So even though they've translated the technology from orthopedics, Vivigen was the product name that's still used in orthopedics and has been quite successful for many years. They've done a variety of things to make it easier for us in the oral cavity. One of the things that's probably the most important is that they've gone to a smaller package size, which addresses your cost concern in that it's not inexpensive, but when you take a more difficult, challenging case, I think that the cost of a cellular bone allograft in there, they have now a 0.7 cc size. So for smaller but yet tougher defects, I think it'll be cost-effective way to try that. Not everybody, has tried it. And so I think that that will help to have the cost a little bit better. With Salvin being the distribution, it's going to help, I think, a lot in terms of ease of ordering, ease of understanding, because they have such a good rep system throughout. So that makes it a little bit easier for people because anytime you're using new technology, there's techniques to it, right? How do you thaw it? How do you store it? How do you order it? So I think those are some of the hurdles, not just cost and particle size. Particle size, one of the things they've done is they've changed their sieve system so that the particle size is smaller for Origin. It's still fairly large, so you have to use rongeurs if you're going to use it for smaller periodontal defects,
Mhm.
but certainly for larger implant type defects, no problem. The particle size is very reasonable for that. And again, if you found it a little big, I've just used a rongeur and made the
Okay.
particle size a little bit smaller. So, those are kind of the main things I think that will make it a positive with regards to the cost, particle size, and user friendly approach that we should see happen in our field as opposed to orthopedics. So I'm excited to see the penetration and see more people get on board. I know a lot of people that have used this as well as other cellular bone allografts, and they've seen great results. And so it's exciting to have something that is off the shelf that can give us the results similar to autogenous bone without those side effects of that second surgical site, the extra surgical time, and the trauma to the patient.
Yeah. No, I had an amazing results as we hold just that for the viewers to understand. That's how we reconnected. Is we did as a committee on doing cases on Origin, and I've had an unbelievable results on cases that I thought I would never be able to regenerate bone. So it's nice to see that you can help somebody nowadays versus back when we did in the 90s. This is something that people forgot in the 90s. As you can recall, we have the DFDBA, we had autogenous bone, and then we had xenograft that came, and that was like the savior. And look at it now. You need somebody like yourself with the PhD to understand all kind of these materials, but it's such a different era.
Yeah, it's exciting to have all these different approaches, technologies at our fingertips. It's definitely fun to kind of see some of the stuff I've worked on for years come to fruition and having people use it as part of their everyday practice.
Yeah. So, what is your word of wisdom that you can give a young clinician nowadays?
That's always a tough one because I get asked that. Sometimes I'll give lectures to the residents and they want they want the pearl, right?
Yeah, yeah. And they're right.
I,
They need it.
it's always nice to have the pearl. I think there's kind of two big things that I always kind of mention to them. I think one of them is pay attention to the details. It's the little fine details that residents are in a hurry to jump onto the next shiny object and things that they've been taught, but they haven't perfected. I'll give an example of good flap management, tension-free release, and proper suturing, and good post-operative instructions. Those are the little details that the residents don't necessarily want to talk about, think about, because they've already been taught it and they want to move on to something bigger and more exciting. But I think paying attention to those little details, if you do a really good job on the small details, I think you get better outcomes because we do have complications. We have patients that don't follow instructions. So, do put the time in on that end of it. Take that extra time to make sure it's tension-free closure. It's like, oh, you're done with the case, everything looks great, but it's a little tight. Well, I'll just suture that down. Well, don't. Back
Yeah.
up, make sure it's tension-free closure, and then you don't have it opening up for you, with complications. The other areas, I mean, more relevant to this discussion, and that is don't be a lagger. It's somewhat embarrassing that there's so many people in our field that don't use any of the growth factors, don't use cellular bone allografts. They're kind of stuck in the 90s. And I think if you look at the research, it's pretty strong research for these different products. And I'm not saying you need to use them on every case, but there shouldn't be any clinician in our field that doesn't, at least in some cases, need to go to one of these approaches that we've sort of chatted about today. I feel that if you're not using any of them, you're a lagger. And unfortunately, when you look at the surveys, there are a lot of people out there that are still laggers when it comes to, these new technologies. So you don't want to jump on too quickly. You want to evaluate the research just because a resident, or excuse me, one of the reps comes in and tells you this is the greatest product ever. You don't want to just jump on and buy it and start using it with no research and no information on it. But when there is research, and you mentioned consensus conference, I mean, we've had multiple regenerative consensus conferences talk about all of these different things that we've talked about today. And I think, there's a role for those that they again don't have to be every case, but they should be something in your armamentarium. And if used properly, it can make your results superior to what they would be without. So I think those are the key things, the details, and don't be a lagger. Those are pretty powerful ways to, I think, enhance your outcomes without it being a pearl of this particular tricky suturing or Professor Corey's, phenomenal results that he
Yeah.
has with the monocortical approach. These are more generic comments that I think apply.
Yeah, no, yeah, you're telling them fundamentals never change, if you don't master the basic stuff, you will never be able to excel in the big stuff. And secondly, as you said, the laggers, but I think that they are more than a lagger. They are not giving an opportunity to our patient to have options, and that's very important. We are here for the service of the patients, and laggers are forbidding the patients opportunities. So now we talked about science and all of that. So let's close it about who is Brett Mc Allister as a person. What is your hobbies? What do you like to do other than playing with the cells all your life? So tell us about you.
I thought work was my hobby. Isn't that? No, I like you do a lot of different things. We do research, we do lectures, we see patients, we teach residents. So I much enjoy all those different activities. But I do find time to do some fun things. I race cars and ski, and I tend to be a bit of an adrenaline junkie. So that's probably my biggest thing is anything to do with adrenaline. I like doing, and living in the Northwest is perfect because we have great skiing at our fingertips. Doesn't mean I still don't go heli skiing up in Canada or
Oh,
go
wow.
elsewhere, but it's nice that locally we are able to drive up to the mountain and go skiing, and our ski area is still open. So we're still doing skiing. Here it is in
Yeah,
April, and
yeah.
having a lot of fun up at Mount Hood and doing that. So that's a little bit of what I do on the side.
Thank you, Brad, for making the time for us. Really appreciate it. It's always fun to talk to you, and I always learn new stuff from you. Anyhow, thanks, and I hope that you all enjoyed that beautiful interview. I think it was very exciting as I was expecting it. And till next time.
All right. Well, thank you so much. It was enjoyable. I always enjoy talking with you and working with you and enjoy our research projects together.
Thanks, Brad. I look forward to see you soon. All
All right.
righty. Take
Sounds
care.
good.
Take care. Bye bye.